Hey everyone, and welcome. You know that feeling, right? A patient rolls in with that crushing, deep abdominal pain, and your mind starts racing. Is this just a bad GI bug, or is it something way more serious? Well, today we're tackling one of the big ones you'll see all the time on the wards, acute pancreatitis. And believe me, how we handle it now is a world away from how we used to. So let's jump right in. All right, so picture this. You're on call, and this exact patient shows up. Classic story. Before you even think about ordering a bunch of tests, there are really only two things you have to figure out, and fast. Number one, is this actually pancreatitis? And number two, just how sick is this person? Let's break down how to get those answers, stat. Okay, first up, the diagnosis. We've got to be sure we're on the right track. The good news? The criteria are actually super straightforward. It's a simple 2 out of 3 rule. And here's the real pro tip. If your patient has that textbook pain story and their lipase is sky high, we're talking at least 3 times the normal limit, then congratulations, you've got your diagnosis. You do not need to rush them to the CT scanner just to prove it. You have your answer, which means you can move right on to the next big question. So, diagnosis is locked in. Now comes the million-dollar question. How bad is it? I'm not exaggerating when I say this is probably the most important call you're going to make in those first few hours. It dictates everything that happens next. Look, you can forget all those complicated scoring systems for a minute. When it comes down to it, the one thing that separates a mild case from a truly life-threatening one is organ failure. That's it. Are their kidneys taking a hit? Is their creatinine going up? Do they need more oxygen to breathe? Is their blood pressure tanking? This is the central question that decides if they go to a regular floor or straight to the ICU. And this slide right here shows the crucial difference. It's not just if they have organ failure, it's about how long it lasts. If it's transient, it gets better within 48 hours, we call that moderately severe. But if that organ failure sticks around for more than 48 hours, that's what we call severe acute pancreatitis. That 48-hour mark is the real line in the sand. Okay, so we know what it is and we have a sense of how bad it is. Now, what do we actually do about it? For literally decades, the answer was always fluids, fluids, and more fluids. But as we're about to see, that entire way of thinking has been completely turned on its head. The old logic kind of made sense, right? The pancreas is inflamed, so if we just flood the patient with IV fluids, we'll improve blood flow and maybe prevent things from getting worse. It feels intuitive. But here's the thing every sharp clinician has to ask. Where's the proof? Is dumping liters and liters of saline into our patients actually helping them? And that brings us to the game-changing waterfall trial. This study finally put that old dogma to the test. Just look at the setup. You had the aggressive group getting a massive fluid bolus and a high infusion rate. Then you had the moderate group getting literally half of that. The goal was simple. See if being super aggressive actually made a difference. And the results were just, wow. Look at this chart. It's not subtle, is it? More than 20% of the people in the aggressive fluids group ended up in fluid overload. Compare that to just over 6% in the moderate group. That's a 3 times higher rate of causing harm. And for what? And here's the kicker, right from the paper. They stopped the trial early. You know that's a big deal. They stopped it because it was so clear that aggressive fluids were hurting people. And the benefit? There wasn't one. 0. No improvement in any important outcome. So more wasn't better. It was just more dangerous. This is a true practice-changing, mic drop kind of finding. So, with the great fluid debate pretty much settled on less is more, let's quickly round out the plan. We need to talk about 2 other big areas, what to feed these patients and whether or not to give antibiotics. The new thinking here also busts some pretty old myths. First, feed the gut. The old days of making everyone NPO, nothing by mouth, are over. We now know that getting them to eat early, if they can, is actually good for them. And if they can't eat, use a feeding tube. Just try to avoid IV nutrition. Second, hold your fire on the antibiotics. Just giving them just in case doesn't help and just breeds resistance. So unless you're treating an actual confirmed infection, don't use them. Phew. Okay, that was a lot. We've gone from diagnosis to fluids to feeding. So let's boil it all down into a simple, actionable checklist you can actually use the next time you're on call. And here it is, your 5-point plan. Nail the diagnosis with the 2 out of 3 rule. Figure out how sick they are based on organ failure.
Give fluids moderately, not aggressively, feed them early, and step away from the prophylactic antibiotics. This, in a nutshell, is how we manage acute pancreatitis today.
The story of fluids and pancreatitis is such a great reminder that we have to constantly question why we do the things we do in medicine. So I'll just leave you with this thought. What other standard of care practice that you see every single day is maybe based more on how we've always done it than on actual solid evidence? Something to think about. Thanks for joining me.